Hi everyone, welcome to Pharmagrid. So today we are going to learn about antipsychotics. So these antipsychotics are also known as neuroleptics or tranquilizers. And these antipsychotics are mainly used primarily to treat schizophrenia, but they are also effective in other psychotic and maniac states. These antipsychotic drugs are not curative and do not eliminate chronic thought disorders, but they often decrease the intensity of hallucinations and delusions and permit the person with schizophrenia to function in a supportive environment. That means these antipsychotic agents are not a permanent cure, but these drugs can improve the quality of life of the particular patient. The schizophrenia is a type of chronic psychosis characterized by delusions, hallucinations, often in the form of voices, and disturbances in thought. The onset of illness is often during late adolescence or early adulthood. It occurs in about 1% of the population and is a chronic and disabling disorder. Schizophrenia has a strong genetic component and probably reflects some fundamental developmental and biochemical abnormality, possibly a dysfunction of the mesolimbic or mesocortical dopaminergic neuronal pathways. So before discussing more about the antipsychotic agents, we should first learn about the dopamine, how it is released. So this dopamine is released by four pathways, which involves the mesolimbic pathway, mesocortical pathway, tuberoinfundibular pathway, and nigrostriatal pathway. So first one, the mesolimbic pathway. Here, there will be increase in dopamine release in psychosis. So this increased dopamine release is responsible for the positive symptoms of psychosis, which includes delusion, hallucination, etc. Next is the mesocortical pathway. In this pathway, there will be decrease in dopamine release in psychosis, which is responsible for the negative symptoms. Okay, so this decreased dopamine release is responsible for the negative symptoms such as social withdrawal, cognitive impairment, etc. Then the third one is the tuberoinfundibular pathway. This pathway mainly maintains the balance between prolactin and dopamine. Prolactin is a milk secreting hormone. So there is always an inverse relationship between prolactin and dopamine. If there is an increase in dopamine, there will be decrease in prolactin and vice versa. Fourth one is the nigrostriatal pathway, which maintains the balance between dopamine and acetylcholine. The overactivity of neurotransmitters, that is the dopamine and serotonin, that is the overactivity of neurotransmitters such as dopamine and serotonin are the major contributing factors for psychosis. Okay, so now we will move on to the classification of antipsychotic drugs. So these antipsychotic drugs are divided into first and second generation agents. The first generation drugs are further classified as low potency or high potency based on their affinity to the dopamine receptor. This classification does not indicate clinical effectiveness of the drugs, but rather specifies affinity for the dopamine, that is a D2 receptor, which in turn may influence the adverse effect profile of the drug. Classification of antipsychotics. So first generation antipsychotics are also known as typical antipsychotics or conventional antipsychotics. So this first generation is again subdivided into low potency and high potency based on their affinity to the dopamine, that is the D2 receptor. So low potency first generation antipsychotics include chlorpromazine, thioridazine. Then high potency examples are fluphenazine, haloperidol, droperidol, loxapine, molindone, perfenazine, pimoside, prochlorperazine, thiothixine and trifluoperazine. Next is the second generation antipsychotic, which is also known as atypical antipsychotics. Examples include risperidone, ciprasidone, paliperidone, iloperidone, lurasidone, olanzapine, quetiapine, clozapine, azenapine. Third generation antipsychotics. Examples are aripiprazole, brexpiprazole and cariprazine. So let's see in detail about first generation antipsychotics. These first generation antipsychotics mainly act by competitively blocking dopamine, that is the D2 receptors. And these drugs are more likely to be associated with the movement disorders known as extrapyramidal symptoms, particularly drugs that bind tightly to dopaminergic neuroreceptors. High potency drugs in the sense those drugs or those antipsychotic drugs having high affinity for dopamine receptor also have high risk for ADR such as extrapyramidal effects. And these first generation antipsychotics are mainly used to manage positive symptoms of psychosis. Then in the tuberoinfundibular pathway, as I have already mentioned in the previous slide, tuberal infundibular pathway, there is a balance between prolactin and dopamine. So what this antipsychotics will do? Antipsychotics will decrease dopamine. So what will happen to prolactin? Prolactin will increase. Okay, there is an inverse relationship between dopamine and prolactin. So the side effect is galacturia. Okay, hence the side effect came galacturia because of the increased prolactin release. Then in the nigrostriatal pathway, which maintains the balance between dopamine and acetylcholine. This antipsychotics will decrease dopamine. So what will happen to acetylcholine? Acetylcholine level will increase, which causes the skeletal muscle contraction, which is responsible for the extrapyramidal side effects. So this is the reason why first generation antipsychotics have high risk for ADR such as extrapyramidal side effects. Second generation antipsychotic drugs. The second generation drugs owe their unique activity to blockade of both serotonin and dopamine receptors, particularly 5-HT2A receptor. 5-HT means 5-hydroxytryptamine receptor. So this is the difference. First generation antipsychotics mainly block only the dopamine or D2 receptors, but the second generation antipsychotics has unique activity to block both the serotonin and dopamine receptors, especially this 5-HT2A receptor. Then the second generation antipsychotics have only lower incidence of extrapyramidal symptoms than the first generation agents, but are associated with a higher risk of metabolic adverse effects such as diabetes, hypercholesterolemia, and weight gain. And these drugs are mainly useful in treating the negative symptoms of schizophrenia. Second generation agents are generally used as first line therapy for schizophrenia to minimize the risk of debilitating EPS associated with the first generation drugs that act primarily at the dopamine D2 receptor. The second generation antipsychotics exhibit an efficacy that is equivalent to and occasionally exceeds that of the first generation antipsychotic agents. So the major ADR or the major side effects associated with the second generation antipsychotics are metabolic adverse effects such as diabetes, hypercholesterolemia, and weight gain. And the second generation antipsychotics are mainly used to treat the negative symptoms of schizophrenia. Refractory patients. Approximately 10% to 20% of patients with schizophrenia have an insufficient response to first and second generation antipsychotics. Such patients are known as refractory patients. For these patients, clozapine has shown to be an effective antipsychotic with a minimal risk of extrapyramidal symptoms. Clozapine is a second generation antipsychotic which can be used as drug of choice or which can be used as a treatment option in refractory patients. However, its clinical use is limited to refractory patients because of serious adverse effects. Clozapine can produce bone marrow suppression, seizures, and cardiovascular side effects such as orthostasis. The risk of severe agranulocytosis necessitates frequent monitoring of white blood cell counts. So the mechanism of action, as I have already discussed, mainly dopamine antagonism as well as serotonin receptor antagonism. So dopamine antagonism, all of the first generation and most of the second generation antipsychotic drugs block D2 dopamine receptors in the brain and the periphery. Next is the serotonin receptor blocking activity. Most of the second generation agents exert part of their action through inhibition of serotonin receptors, particularly 5-HT2A receptors. So now we will see the second generation antipsychotics in detail. Okay, so this clozapine has high affinity for D1, D4, 5-HT2 muscarinic and alpha adrenergic receptors, but it is also a weak dopamine D2 receptor antagonist. Risperidone blocks 5-HT2A receptors to a greater extent than it does D2 receptors, as does olanzapine. The second generation antipsychotics, aripiprazole, brexpiprazole and cariprazine are partial agonists at D2 and 5-HT1A receptors as well as antagonists of 5-HT2A receptors. Quetiapine is relatively weak at blockade of D2 and 5-HT2A receptors. Its low risk for extrapyramidal symptoms may also be related to the relatively short period of time it binds to the D2 receptor. Next drug is pimavanserin. This drug appears to act as an inverse agonist and antagonist at the 5-HT2A receptor and 5-HT2Z receptor with no appreciable affinity for dopamine receptors. Okay, so this is a point to be noted. That is, this pimavanserin has action mainly on the 5-hydroxytryptamine receptor, that is a serotonin receptor, with no appreciable affinity for dopamine receptors. That is why this pimavanserin is indicated for psychosis associated with the Parkinson's disease. We know this Parkinsonism is mainly due to the loss of or degeneration of dopaminergic neurons in the substantia nigra. Because this pimavanserin has no appreciable affinity for dopamine receptors, this drug is indicated for psychosis associated with the Parkinson's disease. Okay, and in this image you can see the relative affinity of clozapine, chlorpromazine and haloperidol at D1 and D2 dopaminergic receptors. Okay, so this clozapine has got less affinity, okay, comparatively less affinity compared to this chlorpromazine and haloperidol. Most antipsychotic drugs have affinities at D2, that is dopaminergic receptors, that parallel the clinical potency. Clozapine differs from typical antipsychotic drugs in having a similar affinity for both D1 and D2 dopaminergic receptors. Okay, so here you can see the relative affinities at D1 and D2 receptors. Coming to the pharmacological actions. The clinical effects of antipsychotic drugs reflect a blockade at the dopamine and or serotonin receptors. However, many antipsychotic agents also block cholinergic, adrenergic and histaminergic receptors. The undesirable adverse effects of antipsychotic drugs often result from pharmacological actions at these other receptors. So first and foremost pharmacological action is the antipsychotic effects. Okay, so this all antipsychotic drugs can reduce hallucinations and delusions associated with the schizophrenia known as the positive symptoms. Okay, positive symptoms reduction is mainly by blocking the dopamine D2 receptors in the mesolimbic system of the brain. The negative symptoms such as blunted affect, apathy and impaired attention as well as cognitive impairment are not as responsive to therapy, particularly with the first generation antipsychotics. Many second generation agents such as clozapine can ameliorate the negative symptoms to some extent. So these positive symptoms are generally treated with the first generation antipsychotics and negative symptoms are treated with the help of second generation antipsychotics. Next one is extrapyramidal effects. Extrapyramidal effects includes dystonias. Dystonias means sustained contraction of muscles leading to a twisting, distorted postures. Then Parkinson-like symptoms, akathisia. Akathisia means motor restlessness and tardive dyskinesia, which means involuntary movements, usually of the tongue, lips, neck, trunk and limbs. This can occur with both acute and chronic treatment. Blockade of dopamine receptors in the nigrostriatal pathway is believed to cause these unwanted movement symptoms. Okay, as I have already mentioned, in the nigrostriatal pathway, there will be maintenance of dopamine and acetylcholine. Okay, so if you are giving antipsychotics, the dopamine level will be decreased, so acetylcholine level will be increased. Because of this, extrapyramidal symptoms will occur. That is why this first generation antipsychotics are mainly associated with this extrapyramidal symptoms. The second generation antipsychotics exhibit a lower incidence of EPS. Next pharmacological action is the antiemetic effects. These antipsychotic drugs have antiemetic effects that are mediated by blocking D2 receptors of the chemoreceptor trigger zone of the medulla. Anticholinergic effects. Some of the antipsychotics, particularly thioridazine, chlorpromazine, clozapine, and olanzapine, produce anticholinergic effects. So, these anticholinergic effects include blurred vision, dry mouth, confusion, and inhibition of gastrointestinal and urinary tract smooth muscle, leading to constipation and urinary retention. So, one exception is there. Even though clozapine causes anticholinergic side effects, instead of dry mouth, clozapine will cause hypersalivation or increased salivation. Okay, so this is the main difference, or this is the main point related to clozapine. Okay, there is one exception. Instead of dry mouth, clozapine causes hypersalivation. And the anticholinergic effects mainly include dry mouth, blurred vision, urinary retention, constipation, etc. The anticholinergic effects may actually assist in reducing the risk of EPS with these agents. Then the other effects include blockade of alpha adrenergic receptors causes orthostatic hypotension and lightheadedness. Then these drugs alter temperature regulating mechanisms and can produce poikilothermia. It is a condition in which body temperature varies with the environment. In the pituitary gland, antipsychotics that block D2 receptors may cause an increase in the prolactin release. Okay, as I have already mentioned, this dopamine and prolactin has an inverse relationship. Okay, when dopamine level increase, prolactin level will decrease. Then sedation occurs with those drugs that are potent antagonists of the H1 or the histamine receptor, including chlorpromazine, olanzapine, quetiapine, and clozapine. Sexual dysfunction may also occur with the antipsychotics due to various receptor binding characteristics. Then weight gain is also a common adverse effect of antipsychotics and is more significant with the second generation agents. So the main adverse effects associated with second generations are mainly metabolic, okay, mainly weight gain, hypercholesterolemia, then diabetes. And here you can see antipsychotic drugs block at dopaminergic and serotonergic receptors as well as at adrenergic, cholinergic and histamine binding receptors. Okay, so this is a summary of pharmacological actions or what all are the receptors in which these antipsychotic drugs bind. Okay, so under this antipsychotic drugs, particularly thioridazine, chlorpromazine blocks this muscarinic receptors. Okay, hence these drugs have anticholinergic side effects. Then particularly chlorpromazine blocks alpha-adrenergic receptors. Then all, but particularly haloperidol, flufenazine, thiothixine mainly binds to the dopamine receptor or blocks the dopamine receptor. Then risperidone, clozapine, both these are second generation antipsychotics mainly acting on the serotonin receptor or blocks the serotonin receptor. Then particularly chlorpromazine, clozapine, they also have actions on the H1 or histamine receptor. Moving on to the therapeutic uses, the first one is for the treatment of schizophrenia. The antipsychotics are the only efficacious pharmacological treatment for schizophrenia. The first generation antipsychotics are generally most effective in treating the positive symptoms of schizophrenia, and the atypical antipsychotics with 5-HT2A receptor blocking activity may be effective in patients who are resistant to the traditional agents, especially in treating the negative symptoms of schizophrenia. Next use is for the prevention of nausea and vomiting. The older antipsychotics, most commonly prochlorperazine, are useful in the treatment of drug-induced nausea. Other uses. These drugs can be used as tranquilizers to manage agitated and disruptive behavior secondary to other disorders. Chlorpromazine is used to treat intractable hiccups. Then pimoside for the treatment of the motor and phonic tics of Tourette disorder. However, risperidone and haloperidol are also commonly prescribed for this tic disorder. Then this risperidone and aripiprazole for the management of disruptive behavior and irritability secondary to autism. Then lurasidone and quetiapine are useful for the treatment of bipolar depression. Paliperidone is approved for the treatment of schizoaffective disorder. Aripiprazole, brexpiprazole and quetiapine are used as adjunctive agents with antidepressants for treatment refractory depression. Now let's discuss about the pharmacokinetics, that is the absorption and the metabolism. After oral administration, the antipsychotics show variable absorption, that is unaffected by food. Okay, exception is ciprasidone, lurasidone and paliperidone, the absorption of which is increased with the food. Okay, so these all are the exceptions, that is these drugs absorption will be increased when taken with food. And these antipsychotic agents readily pass into the brain and have a large volume of distribution. They are metabolized to many different metabolites, usually by the cytochrome P450 system in the liver, particularly the CYP2D6, CYP1A2 and CYP3A4 isoenzymes. Some metabolites are active and have been developed as pharmacological agents themselves. For example, paliperidone is the active metabolite of risperidone and the antidepressant amoxapine is the active metabolite of loxapine. Flufenazine decanoate, haloperidol decanoate, risperidone microspheres, paliperidone palmitate, aripiprazole monohydrate, aripiprazole loroxyl, and olanzapine palmoate are long-acting injectable formulations of antipsychotics, or hence we can say these are kind of depot preparations. Okay, depot preparations. These formulations usually have a therapeutic duration of action of 2 to 4 weeks, with some having a duration of 6 to 12 weeks. Therefore, these long-acting formulations or long-acting injectable formulations of antipsychotics are often used to treat outpatients and individuals who are non-adherent with oral medications. So in this slide, you can see the elimination half-lives of antipsychotic drugs, and you can refer this table in order to learn the half-life. Okay, which of the following drugs has got the highest half-life and which one has got the lowest half-life. Okay, you can refer this image for learning the half-life of antipsychotic drugs. Now moving on to the adverse effects, we have already learned the pharmacological actions of antipsychotic drugs, so it will be easy for us to find out the adverse effects. So the first and foremost one is the extrapyramidal effects. The inhibitory effects of dopaminergic neurons are normally balanced by the excitatory actions of cholinergic neurons in the striatum. Okay, this is the nigrostriatal pathway. Okay, we have already discussed in the nigrostriatal pathway. It maintains the balance between the dopamine and the acetylcholine. So blocking dopamine receptors alters this balance, causing a relative excess of cholinergic influence which results in extrapyramidal motor effects. The appearance of the movement disorders is generally time and dose dependent, with dystonias occurring within a few hours to days of treatment, followed by akathiasias occurring within days to weeks. Then Parkinson-like symptoms of bradykinesia, rigidity and tremor usually occur within weeks to months of initiating treatment. Tardive dyskinesia, which can be irreversible, may occur after months or years of treatment. If cholinergic activity is also blocked, a new, more nearly normal balance is restored and extrapyramidal effects are minimized. This can be achieved by administration of an anticholinergic drug such as benztropine. The therapeutic trade-off is a lower incidence of extrapyramidal symptoms in exchange for the adverse effect of muscarinic receptor blockade. Akathisia may respond better to beta blockers, for example, propranolol or benzodiazepines rather than anticholinergic medications. And the next important adverse effect is tardive dyskinesia. Long-term treatment with antipsychotics can cause this motor disorder. Patients display involuntary movements including bilateral and facial jaw movements and fly-catching motions of the tongue. A prolonged holiday from antipsychotics may cause the symptoms to diminish or disappear within a few months. However, in many individuals, tardive dyskinesia is irreversible and persists after discontinuation of therapy. Tardive dyskinesia is postulated to result from an increased number of dopamine receptors that are synthesized as a compensatory response to long-term dopamine receptor blockade. This makes the neuron super sensitive to the actions of dopamine, and it allows the dopaminergic input to this structure to overpower the cholinergic input, causing excess movement in the patient. Okay, so the tardive dyskinesia is mainly due to the super sensitivity to the actions of dopamine. Okay, because of the long-term use of antipsychotics, there will be long-term dopamine receptor blockade. Okay, so in order to compensate this, there will be increased number of dopamine receptors. So because of this reason, the neurons become super sensitive to the actions of dopamine, and this is a reason for tardive dyskinesia. Traditional anti-extrapyramidal symptoms medications may actually worsen this condition. Valbenazine and deutetrabenazine are inhibitors of the vesicular monoamine transporter, and they are indicated for the treatment of or the management of tardive dyskinesia. These agents cause a decreased uptake of monoamines into synaptic vesicles and a depletion of monoamine stores, ideally focused on dopamine, to address the symptoms of tardive dyskinesia. Next most important adverse effect is neuroleptic malignant syndrome. So we have already learned about extrapyramidal effects, then tardive dyskinesia, and the next one is neuroleptic malignant syndrome. This potentially fatal reaction to antipsychotic drugs is characterized by muscle rigidity, fever, altered mental status and stupor, unstable blood pressure, and myoglobinemia. Myoglobinemia means presence of myoglobin, which is a muscle protein in the blood. Okay, presence of myoglobin in the blood. Myoglobin is a muscle protein. Treatment necessitates discontinuation of the antipsychotic agent and supportive therapy. Administration of dantrolene or bromocriptine may be helpful. So in this slide, you can see a summary of neurological side effects of neuroleptic drugs. So the neurological side effects of antipsychotic drugs mainly involves extrapyramidal symptoms, tardive dyskinesia, and neuroleptic malignant syndrome. Okay, and here you can see the features of each of these side effects. Then their time of maximal risk. Okay, what is the time period? What is the time period by which these type of side effects or these type of reactions can occur? And what all are the proposed mechanisms and what all are the treatment options? So we have already discussed the CNS related or neurological adverse effects associated with antipsychotic drugs. Now moving on to the other effects. Drowsiness occurs during the first few weeks of treatment. These agents may also cause confusion. Those antipsychotics with a potent antimuscarinic activity will cause anticholinergic side effects such as dry mouth, urinary retention, constipation, and loss of visual accommodation. So one exception is clozapine. Clozapine will cause hypersalivation. Then others may block alpha-adrenergic receptors. So such drugs will cause lowered blood pressure and orthostatic hypotension. The antipsychotics depress the hypothalamus, thereby affecting thermoregulation and also causing amenorrhea, galactorrhea, gynecomastia, infertility, and erectile dysfunction. Then significant weight gain is often a reason for non-adherence. Glucose and lipid profile should be monitored in patients taking antipsychotics, as the second generation agents may increase these laboratory parameters and possibly exacerbate pre-existing diabetes or hyperlipidemia. Some antipsychotics have been associated with a mild to significant QT prolongation. Thioridazine has the highest risk, and ciprasidone and iloperidone also have cautions with their use due to this effect. Other antipsychotics have a general precaution regarding QT prolongation even if the risk is relatively low. So again in this slide you can see the summary of adverse pharmacological effects of antipsychotic drugs and their mechanism. Okay, so the first one is autonomic nervous system. Under autonomic nervous system, mainly anticholinergic side effects as well as the side effects mainly due to the alpha receptor blockade. Then CNS related side effects, then endocrine system related, mainly involving amenorrhea, galactorrhea, infertility and impotence. Then other side effects, mainly weight gain. And what all are the proposed mechanism of action behind these adverse effects? Moving on to the cautions and contraindications. All antipsychotics may lower the seizure threshold and should be used cautiously in patients with seizure disorders or those with an increased risk for seizures such as withdrawal from alcohol. These agents also carry the warning of increased risk for mortality when used in elderly patients with dementia-related behavioral disturbances and psychosis. Antipsychotics used in patients with mood disorders should also be monitored for worsening of mood and suicidal ideation or behaviors. Maintenance treatment. Considerable variability is expected in optimal dose ranges between individual patients. Lower doses are generally recommended in first episode patients who tend to be more responsive and more sensitive to side effects, and in elderly who may metabolize antipsychotic drugs at substantially lower rates and are also more sensitive to side effects. In addition, lower doses may be effective for maintenance treatment. Therefore, the dose should be increased gradually, especially in patients who display no response or only partial response, provided compliance has been established and there is absence of dose limiting side effects, particularly extrapyramidal symptoms. So it is always better to start the treatment with a lower dose. Patients who have had 2 or more psychotic episodes secondary to schizophrenia should receive maintenance therapy for at least 5 years, and some experts prefer indefinite therapy. The rate of relapse may be lower with the second generation drugs. So in this slide, I have mentioned the potency and selected adverse effects of representative, conventional and atypical antipsychotic drugs, and you can learn the oral dose of various antipsychotics from here. And in this slide or in this image, they have compared the different side effects. Okay, so let's say for first generation antipsychotics, here you can see the extrapyramidal side effects. Extrapyramidal side effects are more with the first generation antipsychotics and less with the second generation antipsychotics or atypical antipsychotics. Then moving on to the metabolic side effects, which involves the weight gain, hypercholesterolemia and diabetes. And these metabolic side effects are less with the first generation drugs and more with the second generation or atypical antipsychotic drugs. So in this slide, you can see the advantages and disadvantages of first generation antipsychotic drugs. Each drugs, their specific, what all are their specific advantages and what all are their specific disadvantages are mentioned here. So you can refer this image for further clarification. And this one is a continuation of the previous slide. Here, mainly the advantages and disadvantages of second generation as well as third generation antipsychotics are mentioned here. In this slide, I have included the structural formulas of some older antipsychotic drugs. That is the phenothiazines, thioxanthines and the butyrophenones. So, first one, phenothiazine derivatives. This is the phenothiazine nucleus. Examples of drugs that belongs to phenothiazine derivatives include chlorpromazine, thioridazine, trifluoperazine, perfenazine and the flufenazine. Then thioxanthine derivative. Okay, this is the thioxanthine nucleus. Okay, thioxanthine nucleus, and the drug that comes under this category is thiothixine. And the next one is butyrophenone. The drug that comes under this category is haloperidol. Here you can see structural formulas of some newer antipsychotic drugs, mainly the second generation antipsychotic drugs. So we have completed this chapter. If you have any doubts or you can share your valuable comments in the comment section, please like, share and subscribe. Thank you everyone for watching this video. Have a great day.